Patellofemoral pain syndrome, a fancy word for knee pain, is a very common diagnosis and a lot of people suffer from it. Sees tons of different exercise ideas on Instagram, but let's dive into what the research says about how to treat it. My name is Shine Safar. I'm a physical therapist, a board-certified orthopedic clinical specialist, the owner of Unity Physical Therapy, and faculty at my graduate program. I'm also a professional stuntman, martial artist, and breakdancer. I definitely use my knees a lot, and I've treated this case before. But today, let's talk about what the literature says specifically regarding this kind of knee pain. These videos are intended as an educational purpose so that you can make more informed decisions about your care, but they do not and should not substitute a medical exam. If you want to get the best care possible, you should go see a physical therapist or an MD so that they can evaluate you and see what you need to work on. So what is patellofemoral pain syndrome? It's a mouthful, but essentially it just means kneecap pain. Patella is the kneecap, femoral means femur, which is a thigh bone. So when we talk about patellofemoral pain syndrome, we're saying pain around the kneecap. We're not 100% sure what is causing it. Some people think it's compression of the patella on the femur. Some people think it's misalignment. The muscle's not firing the way it's supposed to. So there isn't really a clean association with a specific tissue source. Instead, we kind of make this diagnosis by ruling out other pathologies: ACL tear, meniscus, LCL, MCL, patellar tendonitis, Hoffa's fat pad. Yes, there's a pad of fat in your knee that can be very painful. Everyone has it. And then we have a cluster of tests that if someone's presenting positive with this, that's when we'll say, hey, they have patellofemoral pain syndrome. Although this can be a frustrating diagnosis, it is a little bit of a good thing because it basically means that your clinician or doctor has said that, hey, it doesn't seem like we have anything else going on, such as an MCL tear, ACL tear that might require a little bit more intense management. So in general, the cluster of tests that help us determine whether someone has patellofemoral pain syndrome is A, ruling out other things, and B, that they have pain with squatting, going up and down stairs, even sitting for too long. This is called moviegoer syndrome because you're sitting at the movies for a long time with your knee bent, and after a while it starts to ache. Once we've done our exam and come up with this diagnosis, luckily we have a classification system that helps guide our treatment. The American Physical Therapy Association has 4 categories that patellofemoral pain syndrome falls under: muscle power deficits, mobility deficits, muscle coordination deficits, and just overuse overload without any other impairments. So let's talk about the first one, which is muscle power deficits. This basically translates to the muscles around the knee and hip need to get stronger to be able to do those things that are aggravating us. This is where the knees over toes guy has really come in and demonstrated the power of getting more muscular support. One important note right now is at the time of this video, there's a lot of talk about quadriceps strengthening, which as a matter of fact is one of the muscles that the research shows is beneficial for this diagnosis. However, it shows that you get better outcomes when you combine it with hip strengthening as well. That usually refers to the glute muscles. The glutes are a really strong muscle that sort of sit at the base of the pyramid of our lower leg. If they're not strong, we tend to compensate throughout the rest of our body all the way down to the foot. A famous researcher, Chris Powers, has really showed the importance of having strong glutes for our day-to-day function with anything regarding our legs. So while I do think quadricep exercises are great, it appears that adding glute exercises with that gets better results. Now, what specific exercise to do? That really depends on the patient's profile. Giving them something they're not ready for could cause further irritation. Giving them something too easy won't let them progress as quickly as they should. That's something that you really have to see on the clinical exam. Category number 2 is mobility impairments. Generally, when we classify things in mobility impairments, we think of something as stiff. And that can be the case with the knee as well, as we have some structures on the lateral side, especially the lateral retinaculum and the IT band, that can often be stiff, causing that patella to not have the play that it needs to. And when we loosen them, we get some pretty good results really quickly. However, an important distinction about this case is that can also be due to hypermobility, being too mobile, specifically in the foot. Now, I know that sounds wild, but think about it this way. Patellofemoral pain syndrome is related to activities when you're usually on your feet, such as squatting or going up and down stairs. If your foot is too mobile, you can have a hard time getting that stability, and as a result, your knee might be compensating and causing some strain on it. Think of it as having a shaky base that you're operating under. So, as a clinician, when I have someone coming into the clinic with knee pain, and if we're going down and we find that, hey, this might be more patellofemoral pain syndrome, then we have to say, is it a muscle power issue or is it a mobility issue? If it is a mobility issue, then we also have to say, is it that they're hypomobile around the knee, or are they actually hypermobile around the foot? And so as you can see, this kind of can take a lot of time, but once you get all this, then we can really get to a treatment to help that person much better and faster. Number 3 is muscle coordination deficits. That basically means the person has good mobility, they've got the strength, but the way they're moving is not as optimal and putting some strain on the knee. Now, it's not so common that I see people with amazing mobility and strength when they come to me in the clinic. However, I do work with a lot of stunt people and competitive martial artists, and these people tend to have really good lower leg strength and awesome flexibility as well. People have gymnastics backgrounds and such. And in some cases, what happens is just when they're doing these tasks that irritate them, their knee goes into what's called valgus, which is when your knee kind of collapses inward. This is actually a really fun one to treat because we get to come up with some really fun exercises to teach that person how to keep their body in good alignment while doing some pretty complicated tasks. And the last category is the overuse without any other impairments. This essentially means that on our exam, we'll see that they've got good strength, they've got good mobility, they're moving right. It seems likely based on their history that they've just been doing a lot of strain without allowing the proper time to recover. This is an interesting concept because we always want to push our body, but different parts of our body get to recover quicker, especially depending on how much blood flow they get. For instance, muscle bellies get a lot of blood flow, so they can get thicker and stronger faster, but tendons and ligaments and menisci and cartilage don't get that same blood flow. So sometimes if we're working out really hard, we'll feel really good, we're making gains, and all of a sudden it starts getting really achy. And it's because now you've got these muscle bellies that are really strong, but the supporting structures haven't caught up yet and they need more time to mature. With this, what we're really looking for is load management. So we still want to exercise, but we might have to just adjust the load so that the rest of the body can catch up. So once we classify what group that person gets into, it makes it much easier to get into the treatment. There's a lot of research about this, so I want to talk about some of the interesting things that we found in this clinical practice guideline. The first one I kind of already mentioned before is that combined knee and hip strengthening exercises do better than just one alone. And in the early phase, where things might be really irritated, we actually might lean more towards hip strengthening before we go straight to quad strengthening. That's just because if you're a little irritated, it might not feel good. And instead of getting the hips stronger, we're doing a little more indirect route in the meantime. Number two is taping around the patella actually can be really good for some immediate relief. If you have an important game to play or you just can't tolerate it, taping to support that patella can actually be really effective. Number three is to not use a biofeedback machine to selectively activate the VMO. The VMO is one of the muscles around the quad that's been a hot topic of debate as to whether people can selectively strengthen that. As far as I know now, there's no conclusive evidence that suggests you can do that, which is why probably in this clinical practice guideline, they're saying do not use a machine to do that. Number four is getting foot orthotics. Yeah, believe it or not, foot orthotics can be helpful, especially if we determine that person has that hypermobility of the foot. But one really cool thing that we found is that a custom fancy orthotic is not necessarily superior to just a prefabricated. Meaning, if I determine that someone is in that hypermobility of the foot category and that's what's causing their symptoms, I'll probably just have them get a cheap one first to see how it feels before we look into getting some really expensive custom-made one. We might get the same results and spend a lot less money. Number five is no dry needling. Dry needling is a new thing that's coming out, and not all states allow this for physical therapy, but the research on this one shows it doesn't yield amazing results. So as of now, this 2019 clinical practice guideline says no dry needling. Of course, this is 2019. I'm filming this video in 2023. Things might have changed, and they probably will continue to change. And since dry needling is a new technique, the research might shift on this moving forward. Number six, no ultrasound, cryotherapy, meaning ice, phonophoresis. Basically, a lot of these passive modalities don't show great results with this diagnosis. Instead, we really want to go back to that classification category. Is it mobility, muscle strength, coordination, or overuse? That's where we're going to get the most bang for our buck. Personally, in my clinic, I don't really use those things because I often find that I can get much more with my hands in my evaluation than with a machine. Machines can be a great tool, but can oftentimes lack precision. And lastly, combined treatment shows the best results. And I'm not even just talking about exercise treatment, but essentially exercise with an orthotic if we think it's appropriate, with manual therapy. When you combine all those things, we get better results, and this is supported by the literature. I hope this video helps you understand patellofemoral pain syndrome more, what as clinicians that we're trying to work on when we deal with this. As always, I really recommend finding a good physical therapist to help you in your rehab journey or even in your performance journey, because oftentimes some of these things that we can see during the injury, stiffness, weakness, lack of coordination, if we catch those early on, you can make some tremendous improvements in your performance, get better at a sport, possibly even prevent a lot of these things happening to begin with. Please subscribe for more videos on performance, wellness, and injury recovery. Follow us at Unity PTLA. Go to our website at unityphysicaltherapy.com, and I look forward to seeing you on the next one.
much.